So I'm going to be presenting a case of a patient who had colorectal cancer, and again, thanks to Prof. Goldstein, this is one of his patients. So this is Robert, a 66-year-old man. He was initially diagnosed with hypertension when he was age 50, with a blood pressure around 160, 100. He was put on irbesartan and hydrochlorothiazide, and generally his blood pressure was fairly well controlled. He was also diagnosed with hypercholesterolemia at the same age. His cholesterol at that stage was total cholesterol 6.8 HDL, 0.8, quite high. He was put onto atorvastatin. So he's on medicines for his hypertension and for hypercholesterolemia, and his cholesterol responded quite well. And his other problem was that he was obese. And again, he'd been obese for most of his adult life, with his weight gradually increasing. His BMI was sitting in the late 20s, in his early 20s, and his BMI is now 36. He's tried various diets without sustained success, and then at the age of 63 diagnosed with impaired glucose tolerance in 2015. His fasting blood glucose was a bit up at 6.5, and his 2-hour post-glucose load was 9.2, both in the pre-diabetic range, and he was counselled diabetic weight loss. Lifestyle, he's an accountant. He was sitting at a desk most days, and he gets no regular exercise, and his diet was not great. Low in sugar because of his diabetic diet, but very high in fat and high starch. He didn't get that message. High red meat intake with fairly high dairy and low fibre, with only 2 serves of vegetables daily but no fruit. He is a non-smoker and he drinks 20 to 30 grams daily. And I thought at that point what I did was actually sit down with a cardiovascular disease risk calculation with the Australian Cardiovascular Risk Calculator. His risk of an MI or stroke in the next 5 years was anywhere between 16 and 19%, depending on which tool you looked at. So he's got a fairly high cardiovascular risk with that picture. The plan obviously at that stage was diet and exercise to lose weight, to control his blood glucose, and to try and get his cholesterol down even further. Well, then he was diagnosed with cancer of the sigmoid colon. He had an open resection, which was complicated by his obesity. He had a very high-risk tumour which was invading the visceral peritoneum, with 8 of 14 lymph nodes involved, with some lymphovascular and perineural invasion, and considered to be a very high recurrence risk of 50 to 60%. He had some adjuvant chemotherapy with 2 drugs, 5-FU and oxaliplatin, bi-weekly over a period of 6 months. And really, the questions here are, what were his major risk factors for colon cancer? And how much did his obesity contribute? And how much was due to his diet? And do we have a risk calculator for colon cancer? We have one for cardiovascular disease. Can we put that to the audience and to the panel? What were his risk factors? And how much did each of those contribute?
About diet risk factors for colon cancer. So his red meat intake alone is a convincingly high risk factor for colon cancer. Your relative risk is around 1.3 if your red meat intake is more than 50 grams per day. So 50 grams would be like a matchbox of red meat daily. And there's a dose response seen with that as well. So if you're taking 100 grams of red meat daily, then you've got a relative risk of even higher, 1.35 for colon cancer. And the World Health Organization also considers processed meat a class 1 carcinogen and red meat a 2A class carcinogen. So this would be like frankfurts, bacon, salami, sausages. These are all processed meats, whereas red meats would be like beef or veal. So that was one issue for him. If he was to change to chicken or fish, chicken has no impact on colon cancer risk, but fish would actually be a protector in reducing his relative risk. And this is because of the anti-inflammatory properties and also because it contains unsaturated fat, so it can help to lower his cholesterol. And then also you mentioned he had a low fibre intake. I presume this is because he doesn't take a lot of vegetables or fruit. His intake of vegetables at 2 servings per day is normal. It's not healthy, but this is how the general population eats. So one tip would be not to project your own dietary styles. If you are the general Australian, you're eating 2 serves of vegetables per day, but the recommended amount is 5. So if you think about our lunch today, if you covered half your plate in the salads and the vegetables, this would be considered one serving. He's having 2 plates of salad and veg already, and you're thinking, doesn't seem so bad. But what fibre does is, through a few different mechanisms, one would be creating the bulk in the stool, so this actually dilutes the carcinogens as it passes through as poo. Also, fruit and veg is like a prebiotic. It's a fancy name for feeding your gut bacteria, and so you have a healthier mucosal lining. This is a preventative with colon cancer as well, and also with soluble fibre by lowering cholesterol. So he had a number of ways that he could improve his dietary intake without even changing his body weight. That would have improved his colon cancer risk.
I might like to make a comment about the microbiome effect of diet and colon cancer, because that's a very important area.
No, I think you mentioned it beautifully. The most important contributor to a healthy microbiome is the number of plants that you have in your diet. So the more diversity, the increased number, the variety, obviously feed the good bacteria through probably a prebiotic effect. So prebiotics are products, indigestible components, usually in cell walls of plants and things, where certain good bacteria proliferate because that's their feed. So that definitely will contribute to the, to a better protective effect against colon cancer. It's so directly related to diet that it's and physical activity. So it's the same themes are emerging in colon cancer as in the other cancers. But the other thing, I maybe have missed it, but was there any bowel cancer screening mentioned at all in this case, or? Because that's probably the most effective aspect of bowel cancer prevention is just picking up that kit and doing the FOB, the testing for blood in the stool.
Just while you're holding the microphone, do you have any knowledge of a colon cancer risk calculation?
I've seen a few being touted as potential ones, but in all honesty, most of these things are, it's not as clear-cut as cardiovascular risk prediction. So that's a kind of a moving target, and we've seen some papers being, percolating that are proposing something like that. I think it's far more complex. Colon cancer is far more complex than having something like cardiovascular risk and MIs. Yeah.
Can I just ask, how much of a risk is the obesity per se, or is it the things that are contributing to the obesity that are doing it?
I think the Lancet paper that you showed, that colorectal cancer is actually one of the cancers associated with obesity. But so breast cancer, colorectal, esophageal cancer, liver cancer. I'm not sure what's a fold increase, however.
Do you have a view? Each one.
Obesity is one of the phenotypes, okay? And we had with the second presentation showed, it could be a confounder because diet can have a direct effect or an indirect effect through obesity. So it's not a straightforward correlation. But when some diseases are common in one country, they're very rare in other countries. Like in Australia, we've got 30 per 100,000 colorectal cancer. In West Africa, it's 3 per 100,000. So there are huge variations in lifestyle that affect our bowel cancer risks. And so it's adopting, finding the good things about lifestyles where colorectal cancer is rare and adopting those in some way to places where they're high.
Can I ask you, does bariatric surgery have an effect on bowel cancer risk? Does it reduce risk?
I'm not aware of anything.
David Links is at the back. He's our bariatric surgeon of note. Do you have any, from your reading, anything to say?
Specifically about
Can we have a mic for him?
Yeah.
specifically about bowel cancer risk, but I think there's certainly evidence that bariatric surgery can, in population studies, lower your long-term cancer risk. That's well proven.
And interestingly, bariatric surgery can be the most useful tool for weight loss, but surgery doesn't change how someone eats and their dietary pattern, so it must be coupled with the correct diet advice.
I agree, and in this patient, they may well have diabetes. You can now do an HbA1c to screen for diabetes, and I would be looking for it in this patient and find an excuse for you to be able to use one of the weight loss drugs that we have available to us. Again, you could use the SGLT2 inhibitors or the GLP-1 receptor agonists. They're powerful drugs. They do induce weight loss. And certainly we should be thinking about using them and actually looking for diabetes. Even if this patient didn't have diabetes, they had pre-diabetes, and we have very good evidence that metformin can reduce the risk of progression from pre-diabetes to diabetes. So this patient should definitely be on metformin, and we can use the GLP-1 receptor agonists, liraglutide, under a different name that we use in diabetes for weight loss treatment and prevention in patients who do not have diabetes.
This came up earlier in the day that with regards to all the potential benefits from weight loss, bariatric surgery, etc., not only from cancer prevention but also cardiovascular, less knee osteoarthritis, etc. Is there a group that is pushing the government to perhaps consider having some sort of rebate for these weight loss surgeries? Do you know, David, if any of the surgical groups are pushing for it or any of the GP groups pushing for it?
Yeah. The main surgical group, and it's not only surgical now, is ANZMOS, which is the Australian New Zealand Metabolic and Obesity Surgical Society, I think. And they're very involved as a key stakeholder with the government initiatives pushing in that direction. But I mean, that's been ongoing for 20 years or more, and it's a difficult battle. I mean, there are just about every area health network now has a public metabolic and obesity/surgery clinic set up. So we are making progress. That's being funded by New South Wales Health. So we are moving forward.
Sorry, there are some funded centres now for Medicare patients. So Blacktown for surgery. So Blacktown has got one, Nepean has got one. So that's actually for Medicare, and there is a pathway for referral which is on their website. And the Southeastern Sydney have just joined. So it's still embryonic but starting.
That is true. Yeah. I've tried to get patients into some of those centres, and unless their BMI is 100 or they've got an HbA1c of 10%, it's very hard, and they wait months and months and years. So that is definitely true. It's a great step forward. It's very hard to get patients in.
So, other questions from the audience? We're coming towards the end of our panel session, but
Just want to ask whether bariatric surgery would be then helping reduce the metabolic syndrome and also decreasing the insulin resistance and hence benefiting in that way?
Exactly. I mean, bariatric surgery has been shown, and a bariatric surgeon can comment as well if necessary, but certainly in patients who have diabetes, who are on insulin and many other medications, they are very highly likely to come off their medications and be off their medications at 5 years down the track, depending on the procedure that they've had. And certainly there's a huge improvement in insulin sensitivity even immediately after the surgery. That's partly related to reduction in caloric intake. But certainly it improves many factors, in not only diabetes, but also, as mentioned, their aches and pains, osteoarthritis, psychological well-being, risk of cancer, hypertension, dyslipidemia, cardiovascular risk factors. I mean, obviously the huge weight loss will make a big difference.
These drugs this gentleman's taking, including the other ones that could be helping his weight loss, etc., how are they affecting his microbiota and his microbiome? Could we be in some way actually increasing his chances of obesity by giving him these drugs that could work in an adverse way?
Yeah, it's a very important question. We talked about the effect of medications on the microbiome. The reassuring thing is that metformin actually has a very positive effect on the microbiome. So the fact that it works for obesity, works for diabetes, protects against cancer is a positive thing. The other thing is the statins. They seem to be also heading in that direction, but there are certainly other drugs that might be having a negative impact. So it's quite difficult to kind of extricate all of these things from a kind of a final common pathway. But metformin, I think, has been mentioned as potentially one that he should be definitely on. I don't know about the newer anti-diabetic medications. These haven't been tested yet, but it's something that would be potentially. But the use of this, I mentioned Akkermansia. We ran out of time, but this Akkermansia is it's one of those good guys that might be able to be druggable in the sense that you don't need to administer the live bacteria, but maybe even an outer membrane protein. that could become a supplement for diabetes and obesity and so forth. So this field is advancing very, very fast.
So where does this acromancy occur? What is it? What kind of supplement is it?
I don't know.
Oh, sorry.
No, it's a normal, commensal. So lots of us would have it. Those athletes, people that exercise, would have a proliferation of it. So you can actually culture it. It's very difficult to culture because it's an anaerobic bug. But if you can get a fragment of it that does the same effect, I think that becomes, very popular. There are people working on it at the present time, and I think it's, in the next couple of years you probably see it in clinical practice. Yeah.
So what about people who are not athletes and who just like to exercise and exercise, let's say, 5 times a week? Would they be the ones who would perhaps generate that through their activities?
Yes, if you look at these people, 5 times a week is pretty good, I think. Be enviable of that, so that they'll definitely have a lot of acromancy. Yep.
Okay, so we've come to the end of this session. Could I just remind you that really the rest of today is the opportunity for small group interaction with those who are experts, diet, exercise, obesity, surgery, non-surgical approaches. So many of your questions will be able to be brought out and exposed during that time, where hopefully you've brought some of your own cases for us all to look at. So I'd like you to thank both our 2 presenters and the panel for their expert input.